honorable guests from Director General of Health Services, Government of Bangladesh, respected expert physicians, learned audience, and my fellow colleagues from icddr. Assalamu alaikum and good morning. I am Dr. Aisha Afrin, Research Investigator at icddr. I would like to welcome you all at today's dissemination seminar on Causative Pathogens of Acute Febrile Illness, AFI, and Antimicrobial Resistance pattern in Bangladesh. We are really delighted and honored that our distinguished guests have arrived among us. So, first of all, I would like to request our Executive Director, Dr. Tahmid Ahmed, to announce the inauguration and deliver his welcome speech.
Thank you, Aisha. Distinguished guests and colleagues from icddr, from different institutions, national institutions of Bangladesh, and also colleagues from CDC, Atlanta, as well as from Dhaka, Bangladesh. Assalamu alaikum and a very good morning. I'm very glad to know that, this collaborative work, which was sponsored by CDC, is about to be culminated. And that's why today we have this very important dissemination session. So yesterday when I was talking with Dr. Shubho, I was very pleased to note that, this was done in active collaboration with national institutions in Dhaka city as well as outside. You named the very important medical institutions, Dhaka Medical College Hospital, Chittagong Medical College Hospital, Bhutta, and many other institutions. And they are all involved in this very important study. And I was also very pleased to note that, the professors, the clinicians who are working in those institutions, they are also very much part of this study. They are co-investigators of this study. And I hope that the results, I saw the slides yesterday, and I think that these are tremendous results which you must see. And when these papers are published, I hope that the collaborators from the national institutions, they are also going to be part of the publications. Another important thing that I learned is that, because of this project, there was a huge capacity building done in one particular hospital, and where the laboratory setup was established to diagnose fungal infections. This is something that I was a clinician, we all think about, we hardly find out suitable ways and means of diagnosing systemic fungal infections. So to me, the lab setup has been a real capacity development, so that our clinicians working for the care of patients, they can use this even when the project has been completed and finished. So this to me is another achievement. From icddr, this is actually one of our mandates to work with national institutions. Whatever we do here, we try to disseminate. We also try to have collaborators from these national institutions. One particular example I would like to place before you, and I'm sure that you will very much appreciate the effort taken by icddr. Last year, we had a very unique research fellowship, and this is the birth centenary of the father of the nation, Bangabandhu Sheikh Mujibur Rahman Research Fellowship. And this is exclusively for female scientists in the country. And what we did was to go for a call, nationwide call. Applications came in. These were scrutinized by a team of scientists within icddr. A short list was prepared, and then anonymously this was given to the scientific advisory group of icddr. The SAG is headed by all the very eminent scientists of the world, chaired by none other than Professor Robert Black of Johns Hopkins University. So they reviewed and scored the application, and finally they selected 10. these 10, 5 are female scientists from ICDDRB, 5 are female researchers from public institutions of Bangladesh, including Chittagong Medical College Hospital, Maulana Bhashani University, Shah Jalal University, institutions like that. Now, it's not just giving the research fellowship. The ICDDRB also wanted to make them independent researchers. So, we also had a senior scientist of ICDDRB work alongside them, so that there is also mentoring. But the principal investigator would remain the awardee in that public institution. A money of about $40,000 was given to each of these recipients. So you see that this is quite a substantial amount of money, $40,000 per fellowship. The next question that you might ask is ICDDRB a very rich institution? Can dispense with such amount of money? The answer is no. What is the source of this money? The source of this particular money, the $400,000 that was spent on this Father of the Nation research fellowships, actually came as part of the Conrad Hilton Humanitarian Award that ICDDRB received. And we use part of that money for this fellowship. So you see that this is the kind of improvisation that ICDDRB is currently doing so that it can uphold and promote science, research, not only within ICDDRB but also outside. So again, as I said, that I'm very, very happy to see the results. To me, the results are really very fascinating, eye-opening, and I would welcome all of you to listen to the fascinating presentations by Dr. Fahmida, Dr. Shubho, Mahi, and also our colleagues from CDC. With these words, I welcome you all, particularly our senior clinicians, professors coming from different hospitals and institutes. I can see very well my very close friend and senior Professor Abu Hussain Mullah sitting here. With that, thank you once again. Assalamu alaikum.
Thank you, Dr. Tamid, for your valuable welcome speech. Now, I would like to invite Mr. Daniel Martin, epidemiologist from Global Epidemiology Department of US-CDC, to give us an overview on acute febrile illness.
Executive Director Dr. Tamid Ahmed, leaders of many of the hospitals and health institutions that have joined us today, honored guests, and most finally, my dear friends and colleagues that I have come to value so greatly here at ICDDRB. Good morning, assalamu alaikum, all of you, and may I bring greetings also from my colleagues at the US-CDC in the United States. Thank you so much for your time this morning. As I said, I am Dr. Daniel Martin. I am one of the epidemiologists with the Division of Global Health Protection at the US-CDC in Atlanta. We're here today to talk about a project of acute febrile illness surveillance that we have been doing with ICDDRB now for almost 4 years. A couple of definitions to begin with. As many of you who are clinicians and know far better than I do, acute fever is actually one of the most common presentations with many, many conditions with which a person enters a hospital or a primary healthcare facility. Many acute febrile illness conditions receive no definitive diagnosis, but as you also know, and as the world has reminded us recently, a fever can be an indication of diseases of severe epidemic potential. So we've developed globally a definition of acute febrile illness, which is of fever equal to or over 100.4 degrees Fahrenheit or 38 Celsius, depending on the country we're in, onset within the past 14 days, and no obvious prior reason or focal point for the fever. Why does CDC have any interest in acute febrile illness surveillance? Oops, sorry about that. On the short term, our desire is simply to see that our partners around the world have any assistance they may need to ensure that the collection, the analysis, and the interpretation of data on acute fever is in fact as good as it can possibly be and continues to grow. The long-term goals, though, are really around the concept of global health security, the concept that no disease remains the problem of only one organization or one entity or one nation. Infectious disease knows no borders, infectious disease knows no race and travels around the world. So we wish to be able to build capacity with the countries with whom we work to sustain AFI activities that are already going on, to enhance those AFI activities in ways that are beneficial both to the country and to the globe, and to integrate those AFI ideas not only as research projects such as what we've done now, but for the long view into surveillance around the world and for established ongoing surveillance systems. But perhaps more importantly, goal number 2, data is wonderful. If you publish it, it is wonderful learning, but unless we translate it into actions and policies and guidelines which support the actual health of human beings, it's worthless. So that translational element is our longest term goal probably for the use of AFI work. CDC has now supported AFI surveillance and or research projects in about a dozen countries around the world, many of which are ongoing. We have some new ones coming online soon, and as you can see, Bangladesh is among the very few countries in Asia where we are doing any work right now. There are some more on the horizon. We've been working with icddr specifically on this AFI project. Keeps advancing, my apologies. Since 2018, we began developing our first protocol in 2018. We began writing our first protocol in 2018, began collecting data in 2019 and continuing into 2020. This was 5 different hospitals from the ones represented here today. In fact, only Sir Salimullah in Dhaka has been part of both protocols. We began collecting data in May of 2019, but had to discontinue in March of 2020. As all of you know, COVID came along and basically interrupted every other activity that was going on. Data collection for AFI was among the activities interrupted. Briefly, some results that we did find from the 9 months of data that were collected. We saw a great deal of Salmonella typhi and a little bit of Salmonella paratyphi as well. Perhaps more unexpected or at least novel detections were of Orientia and other rickettsial diseases. And then also we were beginning to see a pattern of Leptospira in the country. I won't go into great detail on these details because they have now been superseded by what is going on in this second phase. And with that, I turn it over to my esteemed colleague Shubho to continue the conversation.
Thanks, Dan, and good morning, everyone. So as you have already learned from Dan about an overview of acute febrile illness and where the studies are going on currently. So he has already described that we have a phase 1 in which we looked at the outpatient department to find out the causes of acute febrile illness. So now I'm going to focus on the inpatient part, that is acute febrile illness and causative pathogens among hospitalized patients of selected hospitals in Bangladesh. So I'm Dr. Tanzir Ahmed Shubho. I'm working for the Program for Emerging Infections at icddr. So I'm starting with the case definition, which as Dan already mentioned. So this is the global definition that is suggested by CDC. So any patient who comes in with fever within past 14 days, who are hospitalized with a fever within past 14 days, we consider that patient as an acute febrile illness, eligible for acute febrile illness. So the body temperature should be either 100.4 degrees Fahrenheit or more, and the fever should be less than 14 days. And also, we enroll patients who are older than 2 months because it's really difficult to get sufficient sample from younger children. We have some exclusion criteria as well. Here you can see that if there are any localized abscess, boil, or cellulitis which can cause fever, we are excluding those from AFI cases because we are looking at the systemic infections. And also, if there are any patient who are suffering from any chronic condition which causes recurrent fever, for example, tuberculosis. So in that case, we don't include those patients as AFI. So that was the case definition. So you have seen, so you hear, why are we doing this study? So if you look at this map, you can see that there are multiple countries or multiple locations where similar type of studies has been conducted. And there they found that besides what they already know, there were some unusual pathogens which were not like known in those geographical regions. For example, in Ecuador, they had St. Louis encephalitis or acute fever, which wasn't a usual pathogen for that country. Also, if you look at Liberia, they have Lassa, that is unreported outbreak, which was also not previously recognized in those countries. So we wanted to see like what are the circulating pathogens in Bangladesh, and what if we can find anything unusual or novel which, besides what we already know, and which are of pandemic or epidemic importance. So with that objective in mind, our study aims to identify the infectious etiology of acute febrile illness among pediatric and adult hospitalized patients of selected hospitals in Bangladesh. So we are actually conducting this study in medicine and pediatric department of 5 hospitals. We have some secondary objectives in which we are focusing on also like the antibiotic use pattern and also antibiotic sensitivity and resistance pattern as well among AFI patients. So these are our study sites. As you can see that we are conducting the study in Chattogram Medical College Hospital, Khulna Medical College Hospital, Rangpur Medical College Hospital, Sir Solimullah Medical College Hospital, and Sylhet Image Osmani Medical College Hospital. So we don't have many health facilities in our study. We have only 5. But if we look at the map here, we tried to select our facilities in such a way so that we can cover all the corners of the country to have a better geographical representation. So this is just a flow chart of what we do in a hospital. So if any patient who are admitted within last 24 hours with our enrollment criteria or inclusion criteria, we assign those patients a number. For example, if there are 5 patients who are admitted in last 24 hours, we give them 1 to 5 numbers, and we randomly select 1 patient given they provide consent. So we enroll that patient. We collect different samples from them. For example, blood samples, urine samples, and also nasopharyngeal samples. We do some rapid diagnostic tests on bedside, and we provide the reports of the rapid diagnostic test immediately to the responsible physician so that they can manage the patient accordingly if there is any positive cases. We also do blood and urine culture and PCR. We actually send those samples to our icddr laboratory, and then we do the test there. So here are some lists of the investigations that we do. We can see that blood culture, so there are 9 organisms and others. So these are not limited to only these organisms. So we have the capacity to do investigate for more bacterial organisms by Vitek 2 system. So also the same for urine culture. We also do PCR for acute phase serum, and we also collect 30 convalescent serum after 4 weeks for each patient. And we do rapid diagnostic tests for dengue, chikungunya, Zika, Leptospira, and malaria. And also for nasopharyngeal swab, we do PCR for SARS-CoV-2, influenza A, and influenza B. In addition, for the blood, we do PCR for Rickettsia species, Orientia Tsugamoshi, and some other organisms as well. So here is the enrollment summary. So this study, our enrollment started from September 2021, and it is supposed to be continued till September 2024. So we are now sharing the findings till April 2023, which is the mid-project dissemination. We just wanted to share our preliminary findings. So here you can see we have enrolled almost 1,710 patients till date. So medicine and pediatric enrollment proportion was almost 50-50. You can see the mean age of the patients was 21.7 years, and the range was from 2 months to 87 years. Gender distribution was slightly skewed towards the male. It is almost 60-40 male-female, and urban-rural differentiation is almost similar. So now let's go to the identified organisms. So what organisms did we identify during our study? So if we look at the rapid diagnostic test results, we did 5 rapid diagnostic tests: dengue, Leptospira, chikungunya, malaria, and both falciparum and virus. So here you can see that there is a considerable number of dengue, which is 4.4%, and some Leptospira is not negligible, 58 and 1270. And if we look at the numbers like distribution, Leptospira was more prominent in the medicine department than pediatric department. So 58 versus 12. We got some chikungunya as well, and some falciparum malaria, and some vivax. Now look at the PCR. So influenza A was actually the most frequently detected organism from our study. You can see that it's a 5.2% positivity. There were some SARS-CoV-2 as well, but I want to emphasize on this Orientia Sutsugamoshi and Coxiella burnetii. We all know that these organisms are really hard to diagnose in our clinical settings. We have to depend on our clinical judgment, but we don't have enough laboratory capacity to confirm these diagnoses. So we want to say that we found some combined Orientia and Coxiella burnetii. We found almost 1.6% positivity for rickettsial diseases. And some Leptospira PCR, I will come to that later. In terms of blood culture, so we all know the blood culture positivity was is low, really low here. You can see here from we got some Escherichia coli, Salmonella typhi, and Salmonella paratyphi. In addition, we want to emphasize on the Burkholderia pseudomeli, which is the disease name is melioidosis infection. So we found one case of melioidosis where this patient was actually admitted to ICU for 20 days, and he was given almost all sorts of antibiotic, and none of the antibiotic was working on him. Then we found our results that this is a melioidosis case, and based on the result, he was given doxycycline, and he immediately responded to the treatment. So after 20 days of ICU suffering, he got recovered within 3 days after doxycycline administration. So that's one of our success story. Like, we have other success story as well, but we wanted to emphasize on this one. There are some urine culture. Mostly it was Escherichia coli. We found 49 cases of Escherichia coli from urine culture. The distribution was almost similar in medicine and pediatric department, and we found some Klebsiella pneumoniae. And in addition, there are some Enterococcus faecium, fecalis, and some other diseases as well. So now I want to focus on the geographical distribution and also seasonal distribution. I want to be careful about at this point, as this is a main project dissemination, I don't want to say that these are the actual seasonal pattern of these diseases, but I want to present what we have observed so far. So if we look at dengue here, we can see that from our study we found that Dhaka, Khulna, Chattogram, they had more frequent dengue than Sylhet and Rangpur. And if we look at the seasonal distribution or seasonal pattern that we have found so far, we can see that there is a, we can't directly say, but there is a pattern during the winter, so October to December during that period. And this actually coincides with the last dengue season. Here is the geographical distribution of leptospirosis. So here you can see that Leptospira, we found Leptospira everywhere other than Rangpur, we found there as well, but more frequent Leptospira was among Dhaka, Sylhet, Khulna, and Chattogram. Highest was in Khulna. And if we look at the distribution, we can see that there is no seasonal pattern for Leptospira. We have found Leptospira throughout the year. So, so one thing is that it's available in all sites, and it's also we're detecting them throughout the year. So that's one thing to consider for the physicians during their differential diagnosis of acute febrile illness. There was one question from all the sites that whenever Leptospira, we haven't found, we have detected Leptospira both by rapid diagnostic test and PCR, and none of the rapid diagnostic test or PCR was positive simultaneously. So they were either RDT positive or either PCR positive. So there was one confusion why we are not getting them in PCR. So I want to show the infectious time course of Leptospira infection, where we can see that Leptospira remains in blood up to 1 week of infection. So we can detect in PCR up to 1 week, and we can see that if you look at the purple line, which is IgM, that is a rapid diagnostic test that we conducted. Here, it can be detected from 4th day to onwards, and it can be detected up to years. The immunoglobulin, both immunoglobulin M and immunoglobulin G. So that's why we didn't find, in most cases, our PCR was positive up to 4th day, the one that we got positive, and from our RDT was positive from the 4th day to 14th day. That's what our findings so far. So I just wanted to explain the reason that why didn't we get both positive in this case. So here's the geographical distribution of scrub typhus and Q fever. So we can see that Rangpur was mostly, the most frequent was from Rangpur, and also Dhaka, Sylhet, Chittagong, Khulna. If we look at the specifically for Coxiella burnetii, which is Q fever, we can see that all of the Coxiella burnetii except one was from Rangpur. So this was, we just wanted to emphasize on that most of the Coxiella burnetii that we got is from actually Rangpur. So physicians from Rangpur might consider like Q fever as one of the differential diagnoses of acute febrile illness. And monthly distribution is mostly around the winter that we have found so far. Now if you look at the overall positivity of our study, at least almost 30% of the patient was positive with at least one infection. It may be viral, it may be bacterial. So at least one infection, almost 30% positivity. And if we break them according to our different investigations, we can see that there was 10% positivity for RDT. Blood culture was too low, I will come to that later. Urine culture positivity 5% and PCR positivity 12%. So another thing that blood culture positivity is only 3%. One of the possible reason I don't want to impose, that many patients who comes to the hospital, in our hospital, they have, if we look at our data, almost 54% of the patients, AFI patients, receive at least one antibiotic before being hospitalized. So, and if we look at the graph on the left, you can see that the top 5 frequently reported antibiotics before hospitalization was cefixime, azithromycin, ceftriaxone, cefuroxime, and ciprofloxacin. And if we look at almost 90% of the AFI patients received one antibiotic during hospitalization. And if you look at the top 5 antibiotics during hospitalization, it's ceftriaxone, amoxicillin, ceftazidime, clarithromycin, and moxifloxacin. So among them, if we look at cefixime, cefuroxime, and ceftazidime, these 3 antibiotics were highly resistant for both blood and urine culture organisms. So one of the possible reasons that we can assume is that because of the high use of these antibiotics, they are becoming resistant for these cephalosporin group drugs. Even though our culture positivity was low, I just wanted to show some resistance pattern for 3 different organisms. So here you can see that Escherichia coli from urine, we had a total 49 cases of identified cases of Escherichia coli from urine. And out of that, ampicillin, nalidixic acid, ciprofloxacin, cefuroxime, ceftriaxone, these cotrimoxazole, they were highly resistant. That is more than 50% case they were resistant in this case. And if we look at Escherichia coli from blood, ampicillin, ceftriaxone, cefuroxime, these were also resistant, almost 50% case, 50-50, resistance sensitive. And resistance pattern of Salmonella typhi from blood, although we have only 11 cases, but we wanted to show what we have found so far. So cefuroxime was highly resistant. Out of the 11 cases, 9 of them was resistance. Same goes for gentamicin and nalidixic acid as well. If we look at ampicillin and cotrimoxazole, their resistance was still, so they were highly sensitive for Salmonella typhi. Now, our highlights from the study, influenza A was found to be the most frequently detected pathogens among AFI patients, followed by Leptospira and dengue. So I wanted to take the opportunity to say something about influenza here. So we also have another surveillance which is going on for influenza surveillance going on in 9 hospitals and 10 from ICDR is conducting in 9 hospitals and IDCR is conducting another 10 hospitals. So in 19 hospitals, and we have seen that the influenza seasonality is around May to September in Bangladesh. So during the monsoon season, so late April to September, which coincides with the monsoon season. So we will really recommend, especially for the healthcare workers, physicians, nurses, as they are the high risk group, to take the influenza vaccine by March or early April. And also, if you have anyone, elderly person in the house, you should definitely consider vaccinate all of the family members, especially like what happens, the kids, they go to school, or the university going people, they go to school, they contract influenza, they don't suffer from the complications, but they contract influenza to their elderly family member and they suffer. The complication is really higher among the elderly population. So we really recommend taking the vaccine by March or early April. Rickettsia, which is less commonly diagnosed in Bangladesh, was identified among 1.6% patients, or even though 1.6% may not seem so high, but we don't have the diagnostic capacity here to diagnose Rickettsia, and I think 1.6% here, it signifies that especially in Rampur area, the physician should consider Rickettsia as a differential diagnosis for acute febrile illness. Some rare pathogens were also identified and remains under further investigations. For example, we found Enterococcus hyli, which is reported in only 10 human cases throughout the world. And we investigated further. It wasn't of any public health concern. So we are actually doing whole genome sequencing to understand much better for this, but it's not a public health concern at this moment. And Leptospira was detected year-round in all 5 sites, so we will recommend the physicians consider Leptospira as a more frequent differential diagnosis for AFI. And 54% of the enrolled patients reported receiving at least 1 antibiotic before hospitalization, whereas during hospitalization, 90% of the patients received at least 1 antibiotic with 13% bacterial positivity. So I want to say potential implications because I don't want to recommend at this moment as our study is already going on. So at this moment, we can say that physicians should consider Leptospira and Rickettsia more frequently during differential diagnosis of AFI. Low-cost diagnostic technique for Leptospira and Rickettsia should be made more accessible in clinical settings. So Leptospira, if we say that Leptospira RDT kit is actually very reasonable, you can get it within 200 Dhaka or something like that. But definitely we have to probably get it from outside, but if proper steps are taken, those can be accessible. So 200 Dhaka is really reasonable for a disease that we cannot easily diagnose in clinical settings. Also, excess groups of antibiotics should be prioritized as first-line antibiotics. So WHO has a classification of antibiotics which is known as AVAR classification, excess, watch and reserve antibiotics. So we should initially consider that excess group of antibiotic in case we don't have the culture sensitivity pattern test readily available. And then after using the excess drug, if the patient doesn't respond or based on culture sensitivity test, we should consider using the watch and reserve group of antibiotics. So that was all from me. Thank you. We thank CDC, our donor, and also we thank our core donors. Thanks a lot.
Thank you, Dr. Daniel and Dr. Shubho, for their well-explained overview and presentation. We will be moving forward with a couple of more presentations. Dear audience, I would like to request you to note down any of your valuable questions or points if you feel to ask, and we will have discussion at the end of all our presentations. Moving forward, now I would like to invite Dr. Fahmida Choudhury, Associate Scientist of icddr. Dr. Fahmida is the principal investigator of all the studies being presented today, and now she will present updates on antimicrobial resistance in communities and hospitals.
Respected Chair, distinguished guests from DGHS and other national and international organizations, learned audience, and my dear fellow colleagues from icddr, good morning, assalamu alaikum. So I'm Dr. Fahmida Choudhury, as was introduced by Dr. Aisha. So today I'll be presenting our study findings that we have already completed, that is antimicrobial resistance in selected communities and hospitals in Dhaka city, Bangladesh. I would like to start my presentation with a culture report you can see here. So this is a culture from tracheal aspirate which detected Acinetobacter species. And you can see here that unfortunately all the antibiotics that was tested, that all are resistant to all the antibiotics. So it was a story of a very unfortunate person, culture report of a very unfortunate person, and my respected clinicians present here, I am sure that infrequently you are now having this kind of report and you are concerned how to treat this kind of patients. So again, I'd like to also mention that about the outpatient, my real life experience that a few months back, two of my close relatives, they reported me that they had UTI that was detected through routine microscopy examination. And both of them were taking oral antibiotics. They just contacted me that they did the urine culture in icddr and waiting for the report, and they were not responding to oral antibiotics. And unfortunately, when the report came, it was found that one of my relatives, she just was sensitive to ceftriaxone and also other injectable antibiotics, but resistant to all oral antibiotics. And other one was only sensitive to meropenem. So the person sensitive to meropenem was hospitalized and was treated in the hospital for 7 days in United Hospital with a bill of 3 lakh. And one of my relatives who was sensitive for ceftriaxone, she was treated at home but took injectable antibiotics. So these are the scenarios nowadays which make us actually concerned, and we need to be aware of that we are actually heading towards a silent pandemic of antimicrobial resistance. So now I'd like to start with my presentation. With the background, I would like to say that antimicrobial resistance has been reported in both community acquired and healthcare associated infections worldwide. So persons colonized with multi-drug resistant organisms are at risk of developing antimicrobial resistant infection. That's why we are always concerned about colonization. So multi-drug resistant organisms have now spread from hospitals to communities worldwide and causing invasive infections. And so understanding the prevalence and drivers of multi-drug resistant organisms colonization in the community and among hospitalized patients is crucial to prevent antimicrobial resistance. So the objective of the ARCH study, we call the study in short ARCH. So the objective was to estimate the prevalence of and the risk factors for colonization with antimicrobial resistance organisms in communities and hospitals. So why colonization? So our goal is to visualize the missingness in current antimicrobial resistance surveillance system. So you can see in this figure that the tip of the iceberg, the thing that we can see, the burden of antimicrobial resistance, we can see only the tip of the iceberg. That is the clinical infection that is detected through MR surveillance and also through different blood culture, urine culture reports. We can see just the tip of the iceberg. But you can see the unidentified clinical infections that is below the line. We can see that burden. And as Shubho mentioned in our AFI study that 3% was reported in blood culture. That means other was not culture positive. I'm sure they were positive, but it was not detected. Even this is the scenario for urine culture as well. And at the bottom, you can see the colonization burden, which is quite undetected. So why we are concerned about colonization? Colonized patient actually later on developed the infection, antimicrobial resistant infection. So we need to be concerned about the colonization burden as well to reflect what the actual AMR burden is. So this ARCH study, it is a multi-country study. You can see here in Asia it is conducted in India and Bangladesh, and in Africa in Kenya and Botswana, and in America you can see in Guatemala and Chile. And you'd be happy to know that Bangladesh through icddr has become a part of CDC's global AMR laboratory and response network from 7 December 2021 through this study. So in this study, we actually looked at 4 different clinical important AMR pathogens. And these are MRSA, that is methicillin-resistant Staphylococcus aureus, ES-CRE, that is extended spectrum cephalosporin-resistant enterobacterial, CRE, that is carbapenem-resistant enterobacterial, and CoLRE, that is colicin-resistant enterobacterial. I'd like to mention here that CDC has declared MRSA, ES-CRE, and CRE as the high-threat organisms given the limited treatment option for infection caused by these pathogens. So in brief, I will just go through the study method. I'll highlight more on the results section. So this was a period prevalence study to take the prevalence of this pathogen, and also an observational study to identify the risk factors. And the data collection period was February 2019 to October 2019. And the hospital we conducted the study was Mugda General Hospital, and two private hospitals, that was Islamic Bank Hospital and Monora Orthopedic and General Hospital. And the community site was the catchment community of that hospital, that is the Kamulapur surveillance area of icddr. Especially we focused on the area that is Mugda, Manda, Maniknagar and Kamulapur, and from this site most of the patients come to this hospital. And the study ward was all the wards except the pediatric and the post-operative ward. So our study population was hospitalized patients aged more than 80 years of ages, and healthy community people that also aged more than 80 years from the surrounding catchment areas. And the sample size was for community, it was 768, for hospital it was 743, and in total it was 1511. So we collected sample, that was nasal swab and stool sample, and after collecting the sample every day we ship the sample to our icddr microbiology lab led by Dr. Dilruba Ahmed, and we have a tremendous support from that. I'd like to mention that, okay, I will talk to that later. So sample testing, for primary testing, culture for isolation of AMR pathogen, we cultured using specific chromogenic agar media that is specific for MRSA, ESCRE, CRE and cholera. So 4 different chromogenic specific agar media, and identification and antibiotic susceptibility testing was using Biotic 2 system. And the isolates were categorized as MRSA, ESCRE, CRE, cholera based on their resistant pattern against specific antibiotics. And also we are doing whole genome sequencing of the isolates. So case definition that we use for AMR phenotypes that are for ESCRE, that is enterobacterial resistance to ceftriaxone and susceptible or intermediate to all tested carbapenem. And for CRE, enterobacterial resistance to one or more of the carbapenems, and cholera, enterobacterial resistance to colistin, and for MRSA, Staphylococcus aureus, resistance to oxacillin or positive by suppository screen. So study findings. I will go to the study findings. Before that, actually we didn't know the AMR burden, that is the colonization burden of these 4 specific pathogens in Bangladesh. So before we had actually our lab was not prepared that much that how much isolates we'll get. When we initiated the study, we were having lots and lots of unexpected isolates that was we supposed to be. So our lab got overburdened. Dr. Dilruba is here, and she was just surprised. We all are surprised that what is this? Why so many isolates? And we were in a troublesome situation with the manpower, logistics. Anyway, we managed. But as we are not prepared at the first step, it was shocking for us to handle all these isolates. So you can see here the prevalence of AMR pathogen colonization among community and hospital participants. This is the data from Bangladesh. You can see that around 80% is most similar in community and hospital, the burden of ESCRE, that is the persons resistant to ceftriaxone. In CRE, that is called carbapenem resistant enterobacterial, that is 37% in hospital and 9% in community. 37% hospital, that could be expected, but why 9% in the healthy community individuals? So again, for colistin resistant enterobacterial, 11% in community and 7% in hospital. So more in community. So why more in community? Possible explanation that we have thought that that in poultry as a prophylactic colistin was used a lot. Now it is banned. So could be persons taking the poultry are having this colonization in these community healthy individuals. And for the MRSA, this is quite same for community and hospital, that is around 20%. And I would like to mention here that recently we had an ARCH investigator meeting, in US-CDC Atlanta, and there all the 6 sites report was presented in a single slide. And the burden in Bangladesh was quite high compared to other countries, even from India. And that is quite alarming. So we also get co-colonization. We found co-colonization of MRSA with ESCRE, CRE and cholera. You can see that ESCRE and MRSA, that is around 16% and 17% for community and hospital. And also for CRE, it is 3% and 8% for community and hospital. So co-colonization is also there. Even for enterobacterial, we also observe co-colonization for ESCRE and cholesterol enterobacterial, that is around 13% and 12% respectively. Even for CRE and cholera, that is 6% and 8% respectively. And the most frequently identified enterobacterials were, that is expected, that E. coli, that was around 75%, and Klebsiella, that was around 20% both for hospital and community. This slide could be tricky to understand at first point, but it is very easy. In this slide, we have shown that antibiotic resistant pattern of E. coli with ESCRE phenotype in communities and hospitals. You can see the antibiotics here, and these are the resistance. The dot, each dot indicates resistance, and these are the number of resistance. So you can, and the blue dots that represent the beta-lactam antibiotics, that is imipenem, meropenem, etopenem, cefepime, and ceftriaxone. So you can see that in hospital and community with ceftriaxone, other antibiotics are also resistant. So just I wanted to show you that it's not only resistant to ceftriaxone, it is also resistant to other antibiotics as well. And in this slide, antibiotic resistant pattern among carbapenem resistant E. coli in communities and hospitals. Here you can see the difference that in hospital, it is quite much compared to communities. So the carbapenem resistant enterobacterials are also resistant to other antibiotics listed here. So it is quite high compared to community. Again, for Klebsiella, you can see here for communities and hospitals. In hospital, this is also quite high. Other antibiotics are also resistant. And this dot, you can see here that we found pan-resistant bacteria as well, Klebsiella, to that was pan-resistance to all the tested antibiotics. So this is difficult to treat resistant pathogen. Nowadays, this term is used worldwide, that DTR, which is making a concern. So what is DTR? Isolates that were non-susceptible to the 3 carbapenems, beta-lactam, and fluoroquinolone were considered likely to result in DTR infection that is difficult to treat. So we found that among the E. coli, 30% had DTR. And 7% had DTR in community. So you can see in hospital it was much more, but community it was 7%, not negligible. And for Klebsiella, it was 13% in hospital and 1% in community. Again, for MRSA, you can see there is not much difference with hospital and community. With oxacillin, other antibiotics were also resistant. You can see here. So now the interesting slide that risk factors for colonization. So what we have found from our study, I think you are very keen to know about that. So here you can see that in the community ESCRE, it is interesting that fresh fruit consumption in the past week, ESCRE colonization was associated with fresh fruit consumption. We don't know the cause. And CRE hospitalization is in last 3 weeks for community participant was the risk factor for colonization. In hospital, for ESCRE, you can see here that stay in surgical ward, then medicine ward was a risk factor for colonization of ESCRE, and hospitalization for 3 to 7 days also was a risk factor for colonization with ESCRE. For CRE admission from another hospital, stay in surgical ward, and hospitalization for 3 to 7 days, and more if more than 7 days, odds ratio you can see that more. So more hospitalization, more chance of development of CRE. And also the invasive procedure and urinary catheter use and also the antibiotic used in last 14 days are the risk factor for developing CRE among the hospitalized patients. So in conclusion, I would like to mention that colonization with 4 clinically important AMR pathogens is common in Dhaka, Bangladesh. Only a minority of participants in both hospital and community settings had no colonization with AMR pathogen. That is, in community we found 16% participant that had no AMR colonization, and in hospital it was 7%. But others were colonized with any of the AMR pathogen. And CRE colonization was significantly higher in hospitals compared to community. And regarding the risk factor, I would like to say that hospital exposures, including rational use of antibiotic, need to be considered for prevention and control strategies for AMR containment. So this was the first stage or first step of our study. We looked at the burden of AMR colonization. As the next step, we will conduct 2 new studies. One is evaluation of health outcomes based on colonization with antibiotic-resistant enterobacterials among hospitalized patients in intensive care units of a tertiary care hospital in Dhaka city, Bangladesh. So we have planned to conduct the study from next month. Our RB is completed. We'll conduct the study in Dhaka Medical College ICU and NICU to detect the burden of ESCRE and CRE, colonization and also the infection. So you have seen that in the first step of the study, we have looked at the colonization. Now we'll explore the colonization and also the infection of ESCRE and CRE in Dhaka Medical College ICU, critically ill patients. And another study that we are in our icddr process, that is evaluation of health outcomes based on colonization with antibiotic-resistant enterobacterial among pregnant women and their infants, a birth cohort study in Dhaka city, Bangladesh. So we conduct this study in Mugda General Hospital and surrounding catchment community, that is Kamalapur. We will enroll the pregnant mother, look at their colonization status and the delivery outcome. And then also we will enroll the newborns, look at their colonization, and also we'll follow that. That will be birth cohort. We'll follow the newborn infants for 1 year and collect samples every month to look at the colonization, new acquisition, or persistence of colonization. So this is in brief of our next plan for this ARCH study. And I would like to acknowledge Communicable Disease Control, DG Health, Center for Disease Control and Prevention, US-CDC for funding the project, Mugda Medical College Hospital, study participants and all our study staffs, and also CDC for funding the project, and also icddr co-donors for all the support all through our research work. Thank you so much.
Thank you, Dr. Famida, for your nice and informative presentation. Now, I would like to request Soyeda Mahi Munir, Assistant Scientist of ICDDRB, to present an update on Candida Auris among ICU patients.
Assalamu alaikum and good morning everyone. I'm Soyeda Mahi Munir, working as an Assistant Scientist at ICDDRB with Dr. Fahmida's team. So now I'm going to present the findings of our study, which is based on Candida Auris. The title of our study is Candida Auris among hospitalized patients in intensive care units of Bangladesh. In background, I would like to say Candida Auris is a multi-drug resistant emerging fungus with serious global health threat. It was first detected in Japan in 2009, and it is causing invasive infection and healthcare associated outbreaks globally with a high mortality up to 72%. It is reported from 42 countries. You can see the data is updated up to 2020. So US-CDC used to regularly update in their website whenever a new Candida Auris is reported from a new country. So when it already spread and reached to 42 countries among all the continents, then CDC stopped reporting on that. So it is already now spread in more than this number. And within very few years, within a decade. So within a decade, some of its strain also became resistant to all 3 available classes of antifungal drugs, which is very concerning. So why should we be concerned of Candida auris? It is because it is often multi-drug resistant, with some strain resistant to all 3 available classes of antifungals. It is sometimes misidentified in lab without specific technology. So it needs advanced level of test and machineries, reagent to properly identify Candida auris. It has also caused outbreak in healthcare settings. Some common healthcare disinfectants we usually use in the hospitals are less effective for eliminating Candida auris. So which disinfectant we should use for Candida auris? So only 70% alcohol or 10% sodium hypochlorite are effective. And it can also be carried on patient's skin without causing infection, allowing spread to other patient or their attendant or even as healthcare workers. So in this map, we can see the colored countries where Candida auris was, the different type of strains were identified. So in 2019, CDC declared Candida auris as a global threat. We can see the 4 different strains were identified from different parts of the world and also in different continents. So it has South American strain, African strain, South African strain, and also East Asian strain. But all these 4 strains are available or they have already spread to USA. And it could be, one of the reasons could be the international traveling. Before I start the study objective, I would like to say that in Bangladesh, Candida auris was first reported in 2009, but it was a part of a master's, 2019. So when it was a part of a master's thesis, and it was conducted in a tertiary care hospital. So when it was reported to CDC, CDC wanted to have a systematic study on Candida auris to see the situation in Bangladesh. Then with US-CDC's fund, we aimed to conduct this study. So our primary objective was to detect Candida auris among ICU patients of selected hospital in Dhaka city, and to estimate the proportion of Candida auris infection and colonization among the ICU patients. So by ICU, we would like to say that we are actually, ICU means ICU, adult ICU, and also neonatal NICU. And our secondary objective was to determine the proportion of multi-drug resistant Candida auris among ICU and NICU patients. So this study was a descriptive exploratory cross-sectional study, and we conducted the study at Dhaka ICU and NICU of Dhaka Medical College and also Bardem Hospital. So we selected one government hospital and one private hospital, and we conducted the study from August 2021 till September 2022. And the study populations were patients of any age and sex admitted in adult ICU and neonatal NICU. From each hospital, we collected we enrolled 400 patients. So 200 from ICU and 200 from NICU. So among each unit, we enrolled 67 sepsis patients and the remaining 133 non-sepsis patients. We have collected skin swab from groin and axilla from all the patients, and if any patient is sepsis, then we collected additional blood sample. So for sepsis patients, two type of sample, blood and skin swab. For colonization, we looked for skin swab, and blood sample for infection. So yeah, so the definition which I was just now mentioning, by Candida auris colonization, we mean that if Candida auris is detected from skin sample or urine, will be considered as Candida auris colonization. And if Candida auris is detected from blood or sterile sites, will be considered as Candida auris infection. And we define multi-drug resistant Candida auris if the Candida auris is resistant to 2 or more of the following antiviral. If they are 2 or more resistant to following antifungal, then we consider it as multi-drug resistant. So the antifungals were amphotericin B, voriconazole, fluconazole, and tescofungi. You can see that the picture of sample collection. So it's blood sample collection from ICU patients and skin swab from NICU patients. Now I would like to share the results. Among the enrolled patients, 8% were colonized with Candida auris, of which 2 of the patients had bloodstream infection. This rate, 8%, is higher compared to other countries or globally. Usually the global rate is about 5%, but in our study we have found colonization rate in ICU is 8%. So among the patients colonized with Candida auris, 46% were identified from ICU and 54% were identified from NICU. And the median age was 55 years for adult ICU patients and 4 days for the neonatal or newborn patient. 60% of all Candida auris positive patients were male. So here I would like to share the proportion of colonization. This is only for colonization. So the proportion of colonization in ICU and NICU and in both our government and private hospitals. The blue bar is showing the result of colonization on admission, and the orange bar represents the test result or the colonization while ICU acquired colonization. So first actually I would like to mention that we have when a patient admitted into ICU or NICU, we have collected their sample on admission and then we followed them up till their discharge. If any patient is tested negative for colonization on admission, then we have followed them up till discharge to see anyone newly developed any new colonization after coming to this ICU. So on admission, if we look at the first bar, so from the government hospital of ICU, so on admission, colonization rate was 5%. So then we follow up all the negative patients who were negative on admission. But so we can see 9% patient developed colonization after coming to ICU. So we have collected this sample after 72 hours of admission till discharge. And in the private hospital of ICU, we can see 2% developed hospital-acquired or ICU-acquired colonization. And I would like to move to private hospital from NICU. There we can also see that 9% patient developed in skin swab, result from skin swab positive colonization, but only the one different, that is in government hospital in NICU. We can see the hospital acquired or ICU acquired colonization rate is lower. That is one exception we have. Now I would like to share the antifungal resistant pattern from NICU. So from the skin swab or the colonization, we can see that most of the or 82% of the neonates had already resistant to fluconazole and 61% to resistant to voriconazole. So in our definition we say if 2 or more resistant to antifungal, then we define it as multi-drug resistant. So we can see that 61% of our neonates were already had multi-drug resistant colonization with Candida auris. Now let's see what's the scenario in ICU. So in ICU, you can see most of the patients, or I can say all of the patients, are resistant to multi-drug resistant Candida auris. So 96% of the patient is already resistant to 2 antifungal, which is fluconazole and voriconazole. We have also looked at other species of Candida. So altogether, we have collected 764 skin swab. Among them, 26% were positive for Candida, any type of Candida. So the most frequently reported Candida species was Candida albicans, which is 28%. Then the second highest frequent was Candida parapsilosis, 18%. This is the scenario of NICU. And from skin swab. So from the blood sample result of the NICU patient, we can see that Candida auris was the most reported Candida species from blood from NICU patient. And in the ICU, we have collected total 752 samples. Among them, 39% was Candida positive. And among them, the most frequently reported species was Candida albicans, just like NICU. So albicans is the most frequently reported species. Then the parapsilosis. And in the blood, we have actually collected, we got only 2 positive cases, Candida cases from blood, and that one was auris, another was glabrata. In conclusion, I would like to say, overall 8% of ICU patients were positive for Candida auris colonization. In most cases, hospital-acquired colonization rate was higher compared to on-admission colonization. Multi-drug resistant Candida auris was more common among adult patients. In recommendation, we would like to say the high Candida auris prevalence emphasized the need to enhancing case detection. Factors contributing to Candida auris colonization should be investigated to inform and strengthen infection prevention and control strategies. Disinfectants such as 10% sodium hypochlorite or 70% alcohol should be considered as infection control measure for Candida auris. Firstly, in our first step, we have looked Candida auris in hospital, particularly in ICU and NICU patient. Now we would like to expand our study, so we are planning to conduct the study in community to see what's the scenario in the community. So our next plan to go for the new study, that is the title is Community Acquired Candida auris among hospitalized patients and their household members in urban Dhaka, Bangladesh. So we have planned to conduct this study from next month, inshallah, and we are going to first, as a first case, whenever new patient admit to the hospital, on the day of admission, as soon as possible, within 1 to 3 hours, we will enroll that patient and collect skin swab to see if the patient is Candida auris positive. If any patient is positive on admission, then we will go to their house, to their household, and we will collect sample from all the household members. So this is our plan. That's how we will look at the Candida auris situation in the community. So this is our study team. And I would like to acknowledge Communicable Disease Control, DG Health, IDCR, US-CDC, Dhaka Medical College, and Bardem General Hospital. We really got their tremendous support throughout our study period. And all our study participants and our study staff, including our lab colleagues. We thank US-CDC for funding and all the time giving us all type of support and technical support. And I would also like to thank our core donors. Thank you.